Good evening, namaskar, namaste, vanakkam, sat sri akal, assalamu alaikum. Welcome to everyone for our sixth webinar. We have planned for total 7 webinars. This is our sixth webinar. Thank you for joining us and giving our young speakers all the time. So before I invite our speaker for the day, let me just give a little bit of, now looking for where is my presentation. Just a second. Yeah, it's there. So just give me a moment. Okay, once again, we are celebrating the Infection Prevention Week that falls in October. And with that, we had 7 young speakers who were all trained for infection control nurse program with Cigna Healthcare. So we are hosting the 7 webinars in collaboration with Nurse India. Nurse India is exclusively for nurses technology platform wherein we are trying to connect the employees with the potential employers. So please check them out on the website www.nurseindia.org, and we do have opportunities for those who are mobile, want to look for different job. I mean, opportunities will be there. So far we have already completed 5 of the webinars, and thank you for joining us. There are many repeat guests over here. Thank you for coming and encouraging our young speakers. Thank you once again. We had Halle speaking about non-ventilator hospital acute pneumonia. We had Rakshita talking about all about extravasation. Rajeshwari on strategies to prevent infections in acute care settings. And then we had strategies to prevent SSI. All these are recorded and they are available on our YouTube channel, Cigna Healthcare YouTube channel. Anybody can go there and watch them and show them to your students, to your nurses. And last we had cleaning and disinfection, environmental hygiene by Amandeep. Right now she's in Canada and she was here early morning her time, and it went off well so far. Many of you had come and blessed these young speakers. Thank you for being here. And today it gives me immense pleasure to welcome Blessy Angel Eunice. And she is going to be talking about CLAPC. And after this, we have our last of the 7 webinar series that will be by Fiba Sibi, speaking on prevention of VAP evidence-based practices. And it will be, if all of you should know that it is no more called as VAP-VAP, it is actually named as ventilator associated events. So come and listen to the difference between what is the CDC guidelines, VAE or VAP, what it should be. So thank you for being here, and see you next time. There's one more webinar. It was scheduled for 31st, but 31st being Diwali, we are moving it to 4th of November, that is next Monday. Hope to see you all then again. And now over to you, Blessy. I will request you to first introduce yourself, tell everyone about a little bit about yourself, and then you can take your session. I will stay off the audio, off the video, and we will take the questions at the end of it. May I request everyone to stay off the video and off the audio, please. Please put off your video because that disturbs the recording. Thank you very much. And also, please remain muted so that you are not disturbing what Blessy has got to share. So thank you everyone for understanding. And Chandrasekhara Reddy, please mute yourself. Do not unmute. Listen to her. You don't need to unmute yourself. Okay. So you can continue to put your questions or any thoughts in the chat box while Blessy is, discussing the topic, and we'll take the questions in the end. So Blessy, you have about 45 minutes, and all the best. And over
Thank
to
you,
you.
ma'am. Thank you so much, ma'am. Good evening, everybody. I'm Blessy Angel Yunus. I am currently working as an MICU nurse in Bombay Hospital, Indore. And I have had the fortune of studying under ma'am and the Signia Healthcare Academy as an infection control nurse. Currently, I'm not practicing as an infection control nurse, but probably I hope I soon get the opportunity of practicing as an infection control nurse as well. Thank you so much, ma'am, for the opportunity that you have given to me. So, without any further ado, I think it's better that we dive into the topic of prevention of central line associated bloodstream infection. Uh, I'll be sharing my screen now. Please put it in the comment box if you are unable to see the screen.
We are good. We can see Blessy.
Can you see me?
We are not able to see you, but we can definitely see your presentation.
I really hope that I don't lose your interest in between. In case you are unaudible, you can let me know. So shall we go ahead with the presentations, ma'am?
Please go ahead.
Good evening, everyone. As you know, we have gathered here to study a little about the strategies to prevent central line associated bloodstream infection. Moving on, the objectives as to why it is important for us to study this topic. To definitely define what do we mean by the term CLEBC, to understand its impact and its effect on healthcare, identifying the key risk factors and strategies to prevent CLEBC. So what do we mean by the term central line and central line associated bloodstream infection? Central line, any one of you tell me where that catheter ends? Every time you're inserting a central line, what area are you specifically putting it into? Can anyone name that vein? You can put it in the chat box. I can see it from here. By the time you guys are putting those answers, let's at least understand subclavian. Okay, subclavian vein, very good. We have got two answers. They are correct. Okay, central line. As the definition says, it is an intravascular catheter that terminates at or close to the heart or in one of the greater vessels of the heart. Internal jugular and clavicle, subclavian, clavicle line, interjugular and subclavian. Very good. Moving on. What do we mean by the term central line associated bloodstream infection? The term has been defined by National Healthcare Safety Network as a primary bloodstream infection that occurs in a patient who had a central line within 48 hours of infection. The onset of infection, before the onset of an infection, the patient has to spend 48 hours of time duration after the central line was inserted into them. Are we clear until here? Moving on, burden of CLEBC in hospital. It's very important for us to understand as to why we have to prevent the occurrences of these CLEBCs in hospitals. The economic burden. $17,896 to $1,29,000 per infection. As you can see, the amount of money that is being invested in treating CLEBC is very much. Unfortunately, we don't have this data for our country, for India. These are all data which are being assessed for the country of United States of America. The clinical burden is also very high, giving a mortality rate between 12% to 25%, which is a lot. Moving on, the psychosocial impact, not only on the patients, but also on the healthcare workers. As we know that if a patient has acquired CLEBC, it is definite that they are going to have a prolonged hospital stay. Now that is going to affect them not only financially, but also mentally. And same impact it is going to create on the health workers as well. It is very important for us to understand the pathoneogenesis of how CLEBC is caused. As you can see in this image, we have different varieties. There are different site of infection from wherein the patient can possibly get CLEBC or the bacteria can transmit. As you can see, the skin organisms. Now there is this term which says endogenous and extrinsic. Can any one of you put it in the chat box as to what do you understand by endogenous and extrinsic? I'm waiting in the chat box, waiting for your messages or your answers. What do we mean by the term endogenous and extrinsic?
Hello, friends. Give some answers, make it more interactive. Endogenous or exogenous? The another word is exogenous, not extrinsic. So maybe you would like to put that. Endogenous means organism, endogenous patient internally, endogenous means origin. Okay. And what is exogenous?
As the word itself says, external or extrinsic.
Intrinsic is outside, intrinsic is endogenous is inside. They already the answers are there.
Correct.
What Blessy has shared, endogenous is from the patient's own skin flora, and
Yes.
the exogenous will be brought in by outside by most common our hands.
Okay. So
And
let's dive into this. The skin organisms, as ma'am has already explained, endogenous means the internal sources and exogenous or extrinsic means the external sources. So, for skin organism, when we talk about skin flora, organisms from our patient own skin. For example, we can take the example of Staphylococcus species, which is commonly found in our skin, right? So these can enter through the bloodstream when there is inappropriate practices during insertion. If the patient is undergoing central line insertion and insertion practices are somewhere down the line compromised, there are high chances that the patient might have these skin floras going inside the central line or inside the bloodstream, which will eventually cause central and associated bloodstream infection. Moving on with the external factor, the healthcare worker hands and contaminated disinfectants. Now, every time we are going for medication giving to the patient, or maybe if you are going for sample collection and you are not performing appropriate methods of hand hygiene, then there are very high chances that these bacteria can be transferred to the patient through healthcare providers. That means you and I. So, we are basically a crucial part in prevention of CLEPSI. Any contaminated disinfectants. Let's say during insertion, you have used any antiseptics during catheter care or during insertion, which was not sterile. So, this is eventually going to cause the pathogens to travel inside the bloodstream. Now, second, the contaminated catheter hub. Again, the endogenous and extrinsic or exogenous part. Endogenous, how will you explain the endogenous when it comes to contaminated catheter hub? Organisms from the patient's own skin or catheter insertion area may directly travel to the catheter hub. Next, it's extrinsic. Again, it comes down to our improper handling or unclean hands, or during line access, you're not performing rub the hub. Because of these reasons, we can contaminate the catheter hub. Next, moving on, we have contaminated infusates. That means whatever you are going to administer to the patient, if it is contaminated, that will eventually cause bloodstream infection. Now, what do we mean by intrinsic contamination? During any manufacturing process, if the fluid that you're going to give to the patient has been contaminated, then it is going to be intrinsic contamination. And when we talk about extrinsic contamination, it is going to occur during administration by the healthcare provider. While I am giving medication to the patient, if I fail to perform the appropriate methods of hand hygiene, rub the hub, and ensuring that the area is clean and dry before administering medication, then it's going to cause extrinsic contamination. And last but not the least is the hematogenous contamination or hematogenous spread, which is caused by the infection from distant body sites, which is going to be there in the bloodstream. It is caused by the systemic circulation. Like, let's say your patient had some kind of infection in some distant part of their body, which has now traveled through the bloodstream to your central line area and has now caused the infection. I hope we are clear until here now. Now, as you can see in this picture also, this is exactly what we have just discussed right now. First part, catheter contaminated at the insertion site, which is the extraluminal contamination. Now, what is extraluminal contamination? It is nothing but the contamination which has occurred outside the catheter lumen. Okay, it can either be done through the external surfaces during at the time of insertion, or inappropriate dressing methods, inappropriate cleaning during insertion and dressing. Followed by the second one, catheter hub manipulation by the hospital staff, which is also called the intraluminal infection, intraluminal spread. Now, this can be done when microorganisms are entering the internal lumen. That is during when we are performing medication administration to the patient, or we are taking blood. In any of these cases, or else we have touched the catheter hub without clean hands or without wearing gloves, it is during these places that the intraluminal spread can happen. Now, common organisms that can be transferred will be gram-positive bacteria or gram-negative bacteria. And fourth one is contaminated infusates, as we have already discussed. Now, every time these bacteria are coming, they are going to the catheter lumen and they will create a biofilm there. And within this biofilm, it is a very good site for all the microorganisms to collect in that one place and harbor and multiply there. That is how it is going to worsen the bloodstream infection. It will worsen the situation of the patient. Now, as we have understood as to how the infection is getting prevented, we have discussed the importance of maintaining clear insertion bundles, following all the requirements that are to be done during insertion, the maintenance, cleaning of the sites, everything we have discussed. So now let's move ahead with the most primary part of our session, which is the prevention of CLEPSY. First and foremost, we have the insertion bundle. Under insertion bundle, it is very important for us to assess whether the appropriate vein has been chosen for inserting the CVCs or not. Then we have to ensure that appropriate hand hygiene has been practiced. By appropriate hand hygiene, what do we mean? You have to perform surgical hand washing. Then you have to go ahead with proper donning and doffing of the PPE kits, along with proper cleaning of the skin with CHG or chlorhexidine gluconate, and ensuring that full sterile barriers are being used. Next is the maintenance bundle. Under maintenance bundle, we have to assess the daily assessment of the central line, whether the patient needs central line today or not, followed by the catheter skin care, the catheter hub, cap, and tubing care. We all are probably following the CLEPSY bundle checklist, under which all of these criteria are to be followed. Now, next, hand hygiene before manipulation of the intravenous catheter system. Every time you're going to assess the catheter hub for any reason, can be for medication administration, it can be for taking blood samples, it can be for administration, it can be for cleaning purposes. For any reason, if you're going to assess or touch the catheter site, you have to ensure that you have performed appropriate hand hygiene. We have also discussed nowadays, I think in your hospitals also, I'm pretty sure your ICN must be focusing on rub the hub practices. That is nothing but just to prevent every bacteria that is there on the hub to be washed away before you administer the medication. So you have to take your alcohol-based gauze pieces and then perform the rub the hub before administering medication to the patient. We also have to ensure that the site of insertion and the area of central line has been kept clean and dry. Along with it, the very primary crucial factor is also timely dressing and changing of dressing, and ensuring that central lines are being dressed with CHG transparent dressing. Chlorhexidine dressings are nowadays in use, which is also called CHG impregnated sponges. So we have to ensure that they are being used in our hospitals. Now, moving on. These are some essential practices. By essential practices, what do we mean? Essential practices are nothing but which are to be followed in every patient. These are basic practices which cannot be skipped at the time of insertion, or before insertion, after insertion, or anywhere during that procedure. This is a common set of practice that will follow for every patient. Okay. Now, for essential practice before insertion, we have to first and primarily assess whether the indications are there, whether the patient needs CVC or not. We have to minimize unnecessarily CVC placements. We have always seen that doctors actually assess whether the patient needs CVC or not. If the patient is not in need of long-term prolonged medication support, or the medications are just basic medications which can be given through the peripheral lines, then we have to unnecessarily avoid pricking the patient and giving them central venous catheters. Next is to ensure that anyone, the healthcare team member who are going to come across or who are going to handle, be a part of the insertion team or be a part of the care team and maintenance team, they have to have appropriate education with regards to competency when it comes to handling the central line. Then last one is high evidences have been shown on the basis of evidence-based practice. It has been shown that any ICU patient with who is more than the age of 2 months, we can give them chlorhexidine preparation bath on a daily basis. This is actually effectively shown to have reduced the number of clepsy, evidences of clepsy. Okay. Now, moving on, at the time of insertion, what are the criteria that are to be followed? I think all of us are pretty much aware of what is to be followed at the time of insertion. Can some of you at least highlight a few points, like just a few points that you are following in your hospital during the time of insertion? What all things you are following? We have just discussed some basic criteria.
Come on, friends, some answers there just to make sure that you all are listening. Skin preparation, site selection. Somebody had asked percentage of CHG for skin disinfection. Any of the audience would like to answer that question? What percentage of CHG is that you are using for skin prep while you are inserting and also when dressing?
2% chlorhexidine.
2%. Okay, okay. Great. Anybody else using anything else? 5%.
It's 2%.
The recommendation is 2%.
2%.
Please go back and check your available CHG. For all you know, it is 2%. Maybe you did not pay attention. We'll talk about it, what happens when we use more than recommended concentration of disinfectants at the end of the class. Okay? Yeah, Blessy, go ahead.
Okay, let's move on. At the time of insertion, what are some of the crucial elements that should not be missed at the time of insertion of central lines? Firstly, to begin with, in any ICU or non-ICU setting, we have to have a checklist in which we are ensuring that there is adherence to every infection prevention practices at the time of insertion. That can include multiple factors, and every hospital has their own set of guidelines as to the checklist is concerned. Next is hand hygiene is mandatory to be performed before catheter insertion or before you're going to touch the catheter also. So you have to ensure the performance of hand hygiene. Followed by, according to the studies, they have preferred subclavian site is preferred in order to reduce the risk of infection or complication whenever the central line is being placed in ICU settings. However, for infants or children, femoral vein catheterization may be considered if upper body sites are contraindicated. Patients who are receiving or likely to receive hemodialysis, these are the patients in which subclavian site should be avoided due to the risk of stenosis. So we can avoid it for patients who are going to have hemodialysis or can be planned for having hemodialysis in near future. Otherwise, we have to always ensure and encourage the use of subclavian lines, as the number of incidences of clepsy in patients with the site of insertion as subclavian has less number of CLEPC. Followed by, we have to use an inclusive catheter cart or kit. Now, what do we mean by that? An inclusive, it is basically a kit which contains all the necessary components which is essential for aseptic catheter insertion, and it will be very easily available in any pharmacy. So we have to promote the usage of such things. Followed by the usage of ultrasound guidance for catheter insertion. Now, this quality of evidence is very high when it comes to using ultrasound guidance at the time of catheter insertion. Why are we saying this? Because whenever we are using USG guided catheter insertion, there are less chances of pricking the patient multiple times, eventually reducing the risk of insertion site CLEPC. Causes of insertion at the time of insertion, the compromisation of practices will not be there. Followed by using maximum sterile barrier precautions during CVC insertion. As many times you will be, every time a doctor is going to perform a CVC insertion, the number of times someone is going to come and give them interruption, we have to reduce that. We have to ensure that maximum sterile barrier precaution are being followed. Now, what all can be the barrier precaution? A sterile gloves, a mask, a cap, sterile gown, and we have it is to be worn by everyone who is a part of the insertion team, including the nurse who is assisting the doctors during insertion, the doctors or the intensivist who themselves are performing the central line insertion. Correct? And followed with, there have also been evidences which has proven that the patient are to be covered with a large full body sterile drape during catheter insertion. So we have to ensure, or we have to promote the use of maximum sterile barrier precautions, such as ones that I have mentioned right now. Followed by using an alcoholic chlorhexidine antiseptic for skin preparation. We have always highlighted the use of CHG alcohol-based hand rubs or antiseptics every time we are performing insertions or something like that. Now, moving on. These were all the precautions that were taken during the insertion part. What about after insertion? Every time the patient has central line if let's say if we are practicing in an ICU environment, we all know that the patient ratio in ICUs are very strict, especially for patients with central line or catheters. We are following 1:1 or 2:1:2 ratio. Why is that important? In order to ensure that cross contamination or there is less cross contamination among the patients. And as there is also one more point mentioned, use of float nurses in the ICU. We have to reduce the number of floating nurses working in the ICU as minimum as possible. The nursing staff who are deployed for ICU should be there, placed in ICUs, deployed in ICUs, and they should, because they are the ones who have been taught and who have the skills of dealing patients who already have central line. Followed by use of chlorhexidine containing dressings for CVCs in patient over 2 months of age. If we leave the part apart for infants, anyone over the age of 2 months of age, we have to use CVC dressings which contain the CHG part. Now, for non-tunnel CVCs in adults and children, transparent dressings can be changed, and we can use non-CHG based transparent dressings also. And just give me a moment, let me have some water. Now, for non-tunnel CVCs in adults and children, we can use transparent dressings, and we have to ensure that the site care has been performed on a daily basis with the use of CHG-based antiseptics on every 7 days. If you are using CHG-based dressing and if they are not soiled, we continue with it. But if it is soiled, you have to ensure that it is being changed. If we are observing that the dressing is soiled or it is loose, it's damp, you have to ensure that it is being changed. If you are going to use gauze dressing on your patient, which is not recommended, but if the patient is having active oozing and you're using gauze dressing, it has to be changed in every 2 days, or as earlier as possible. If you are saying that it has been contaminated completely, it's soiled with blood, please change it immediately as soon as you see or you find it damp or contaminated with blood. Next, you have to disinfect the catheter hubs, the needleless connector, and injection ports before assessing the catheters. As we have just mentioned, every time before we go by assessing the catheter hubs for medication administration, we have to ensure that we have not only performed hand hygiene, but we are also clearing the port, the area from where we are going to access it. So we have to disinfect that part of the catheter hub also. And any non-essential catheters which are not needed are to be removed. And routine replacements of administration sets which are used for blood or blood products or any lipid products are to be removed. You have to use it one time, one day. And nowadays, lipid formulation, we are changing it in 7 days also. But it is prescribed that after you have used any blood, any IV set for administering blood, you can change it. And for any IV regular sets through which you are just administering any fluid to the patient, we can keep it till 7 days. And the quality of evidences is again very high. And apart from that, you have to perform surveillance for clepsy in ICU and non-ICU setting. This is to be done by the ICNs, and as we are all pursuing infection control nursing right now, and we're trying to reduce the number of incidences, we must ensure that clepsy, surveillance of clepsy is done appropriately and very proactively in ICUs as well as in non-ICU settings. So these are the essential practices that are to be followed before insertion, at the time of insertion, and after insertion. I hope we are clear till here now. And followed by these are some additional approaches which can be done in order to ensure that further these are just basic additional precautions to ensure that clepsy doesn't happen. So as we have already discussed, using antiseptic or antimicrobial impregnated CVCs. And the quality of evidence is again very high in adult patient, but it is moderate in pediatric patients. Apart from that, antimicrobial log therapies for long-term CVCs can be used using recombinant tissue plasminogen activating factors once weekly after hemodialysis in patient undergoing hemodialysis through a CVC. If a patient is undergoing CVC, hemodialysis through a CVC, these are to be followed because the evidence of quality of evidence is very high in these areas. Then utilizing infusion of vascular access teams for reducing clepsy rates. We can actually make a separate team which is entirely dedicating themselves for assessing the bloodstream infections for clepsy. We can make a separate team and they can be utilized just to assess whether the clepsy rates are not raising high, how are the central line bundle checklists, whether they are being followed or not, all the checklist, the criteria that are mentioned in the checklist, whether they are being followed or not. Now, there are some approaches that should not be considered as a routine part of clepsy prevention. It is very important we are mentioning all the parts that are to be used, that are the approaches that are to be used to reduce clepsy. But these are some very important considered thoughts that are not to be followed in order to prevent clepsy. The first point is do not use antimicrobial prophylaxis for short-term or tunnel catheter insertion or while catheters are in situ. We have to reduce the usage of antimicrobial prophylaxis if the catheter site insertion, if we are going to place the catheter for a short-term duration, because the more number of antibiotics we're administering to the patient, we all know the side effects of antibiotics and also the possible antibiotic resistance that the patient's body can develop. So we have to avoid doing that. And we also have to avoid routinely replacing CVCs or arterial catheters. If once we have inserted it, we have to properly assess whether the patient needed that CVC or not. And once you have assessed it, you have inserted it, then avoid reassessing, routinely replacing those CVCs. There are still some unresolved issues that remains. These unresolved issues, to begin with, are the routine use of needleless connectors as a clepsy prevention strategy before an assessment of risk, benefit, and education regarding proper use. The original purpose for which needleless connectors were introduced was to prevent the needle stick injury During intermittent use, we have been using administration of medication are done frequently for patients who are with central line. So the primary reason for the usage of needleless connector was to reduce the incidence of needle stick injury. So we don't have any abstract data, exact data, which actually proves that whether they have a significant role to play in clepsy prevention or not. So these are some unresolved issue for which we are still working on. We are still working on these things. Second, surveillance of other types of catheter. Now, what do we mean by other types of catheter? We know that patients also have peripheral arterial catheters or short-term peripheral venous catheters. And unfortunately, every time we are assessing the incidence of bloodstream infection, these catheters are not included in most of the surveillance system, although they also have a very high risk, a very potential part in playing uh, for contributing into bloodstream infection. So hopefully in future surveillance systems, we should consider including bloodstream infection associated with these type of catheters as well. Now moving on to standard non-antimicrobial transparent dressing and clepsy risk. Non-antimicrobial transparent dressings are the simple transparent dressing which are visible, which in most of the hospitals we are using for peripherally inserted for regular peripheral lines that we are accessing to the patient. Under that, we are using the non-microbial, non-antimicrobial transparent dressing. So there haven't been any exact studies that have been conducted where it proves that they will reduce the risk of infection for patients like that. And same unresolved issues are the impact of sutureless securement devices in reducing clepsy. It is till date unknown. Followed by the impact of silver zeolite impregnated umbilical catheters in preterm infants. We don't have abstract data for all of these issues. So we are yet to discover it in future. Now we'll move on to the next slide. Now that we are discussing a lot more about the CHG dressing, the chlorhexidine dressing, it's very important for us to also understand as to how they are supposed to be placed. Now, when you look at these pictures, please have a look at these images. Now, what do you see here? They have used a transparent dressing, but unfortunately, the site of insertion is not at all visible. Can you see the site of insertion? Can you see if the patient is going to have is having primary signs of infection, any sort of redness or anything? Is it visible here? All we can see is that this site of insertion is covered with this thick gauze piece dressing over which they have placed a CHG impregnated dressing. As you can see it here, the CHG part is just slightly over here, slightly visible here. Is it clearly visible to all of you guys? Ma'am, can you please tell me if my markings are visible on the screen?
Yes,
Yes,
ma'am.
yes.
Okay. So we have to avoid placing our gauze pieces like this because the primary reason you're using transparent dressing is to ensure that the site of insertion is visible. If you're unable to do it, it is simply waste of your resource and your money. See, now in the next picture, let's go on to this picture. Let's focus on this picture. So where is the site of insertion? This is the site insertion. Where is this CHG impregnate dressing is supposed to be placed? This is supposed to cover the exact site of insertion, whereas it is covering everything else but the site of insertion. It is clearly visible to you guys. It is not covering the site of insertion. Ideally, the CHG should extend beyond the insertion site an inch. That means the part where is the CHG, where this thick part, as you can see, the thick part is to cover the insertion site and it should extend a little an inch over the insertion site. Now, what you will do if you find a dressing like this, the intervention is very clear. You have to change the dressing. If you're unable to site the insertion site, you have to change the dressing. And if the blood goes beyond edges of the CHG pad, the thickness wala part you can see here, if it is going beyond that, you have to change the dressing again. Now, now in the third image, you can clearly see this area. If you will clearly observe it, this area is very thickened and it is thickened due to blood. Now, the CHG is not coming in contact with the site of insertion, and eventually the blood which is getting accumulated here is going to be a very good area for harboring of the microorganisms. So, if 80% of blood is on the CHG pad, you can see it clearly here, and nobody has bothered changing this. Now, the CHG area has already been covered with blood. Apart from that, the blood has moved on till here. It's completely spreaded. Can you see that? Now, if your CHG dressing is looking like this, and if the pad is having like a little pitting edema, it means the CHG is no longer active because it has already it has already absorbed too much of blood. That means you eventually have to change it. And if the site is continuing to bleed, if it is an active bleeding, if it is actively oozing, you can use hemostatic agents, or you can place CHG on top of it. And then this dressing, if you are seeing you have placed the CHG dressing and the active bleeding is still there, then you have to change it after 2 days or 48 hours. And if you're observing that again there is pitting edema, you cannot wait till 48 hours to complete. If you are seeing that the CHG has been completely contaminated with 80% of blood, and as we have just discussed, the pitting edema has been found by you, you have to immediately change the CHG dressing again. Are we clear till here? I hope you have no doubts till here. Now, this is one of
yes.
now this is one of the most crucial parts as to implementation of CLEPSY prevention strategies. We can have all the knowledge about CLEPSY prevention, and if we are unable to successfully run this program, it's going to be a waste. So we have 4 E's here: engage, educate, execute, and evaluate. Now, who all are we supposed to engage? The key stakeholders. And why? Who all are the key stakeholder? It is not just the healthcare workers, including the doctors or the nurses, but also the senior leadership, the management people. We have to engage we have to ensure that they're also actively participating here in CLEPSY prevention. We have to tell them the economical burden and that's going to be there as an effect of increasing CLEPSY rates. So we have to ensure that there's active engagement from the healthcare workers as well as from the patient, and from the senior leadership champions. Now, educate. Educate. What do we need to know, and who all do we have to educate? When it comes to educating definitely has to be we have to educate the healthcare providers, including the doctors and ourselves, the nurses. Why it's important to educate? Because we are the primary ones who are going to deal with it. If anywhere we are lacking our knowledge or our skills, then eventually we will be the ones who will be giving infection to the patient. Hence, it's very important for us to train the healthcare workers, the patients, and every caregiver who's involved in the care of a CVC. They have to be trained. How that can be achieved? We can actually give them appropriate indications prior to insertion. We can tell them when all do we need to introduce a CVC catheter. We have to use full barrier precaution at the time of insertion, and daily evaluation of necessity of the device. You have to educate with regards to all of these points, whether the CVC was needed, and now that the CVC has to be inserted, whether all the points of insertion and maintenance bundles are being followed or not, and daily evaluation for the need of it. Now, this can be done from both the side, from the doctors as well as from the nurses, followed by the execute. What do we need to do and how we can make these things happen? We all have discussed about, we just have discussed about the CLEPSY checklist. A standardized competency assessment checklist should be followed in order to ensure that none of the parts or the points are missing. So you have to ensure that you are not just educating the nurses and the families, but you're also maintaining a checklist which is ensuring the proper following of all of these components that we have taught to the healthcare providers. Apart from that, the education is also to be given. Now that we have planned everything, the execution part is also to be done by the family members. If we are changing the healthcare setting, until now the patient was with us in a hospital, in an ICU setting. and now for some reason they are going to take that person to their home. We also have to educate them with regard to the same practices that are being followed, that were being followed by us in the hospital setting. That is only when this is going to be executed, because clepsy does not only happen here now, it can occur in any setting. So you have to also ensure that as a part of execution, we have to give enough information to the family members as well. And last is evaluation. And how do we know? We have engaged everyone, we have educated everyone, we have executed everything possible. We have now we have to evaluate. Well, how do you evaluate? We have to go ahead with feedbacks. That can be periodical feedback, or that can be a daily round assessment by the infection control team, by the link nurses. Evaluation, periodical evaluation may happen monthly or quarterly or on a daily basis. It depends on the policies of the hospital. As every hospital has their own set of policies. Now, in my hospitals, the ICNs come for daily rounds and they actually evaluate whether the clepsy bundle checklist are being followed on an everyday basis or not. Now, it's not just a formality for us to just tick down and just do it as a formality. We have to ensure that every part of that checklist is being followed appropriately. So that will be a part of evaluation. So anytime you're going to go ahead with this entire clepsy prevention strategies, you please have to ensure also that evaluation is a crucial element of it. Are we clear until here? And these are the references on the basis of which I have made this entire PPT. It has been given by the SHIA IDSA EPIC strategies to prevent central line associated bloodstream infection in acute care hospitals. If you want, you can take a screenshot. You can actually refer to these references for more details into it. And that is it from my side. Thank you so much. I hope this was not informative for you guys. Now I would like to hand it over to Tankam ma'am. Thank you, ma'am.
Thank you, Blessy. That was a wonderful deliberation. So there's a lot of questions we will try to answer because we told them that we will take it at the end. So chlorhexidine strength, ladies and gentlemen, recommendation is 2%. So I asked a question, what happens when you use chlorhexidine that is more stronger? If you use that, what can it lead to? Anybody has any idea?
Ma'am, skin irritation.
Sorry?
Skin irritation.
Okay, skin irritation. Well, there's something more serious. Anyone? See, I think all of us know that all these webinars that we did, we are trying to bring whatever is the evidence-based practices, right? It's very important to follow evidence-based. And we know, just like not recommended antibiotics, same like overuse of disinfectants can also lead to antimicrobial resistance. Okay, so that's why it is very important to know what is the evidence saying. If it says 2%, that's what the research has proven, that's good enough to disinfect that site. So there is no need to overuse it, you know. Then skin irritation, of course, that is local, but more than that, it can lead to antimicrobial resistance. So that's important. And let me get back to the questions. So how frequently we need to change IV sets and how frequently we need to change lipid? All these were actually discussed. So what Blessy mentioned in the compendium, the SHIA document is actually a compendium of multiple bodies coming together and putting all the evidence which is available. CDC talks about changing, the last guideline talks about changing non-lipid blood and your other drugs, like your what you call the white drug, the lipids, blood,
Propofol.
propofol. Yes, thank you, propofol. So propofol needs to be changed every 12 hours and lipid every 24 hours, blood with every unit. So apart from that, if the line is continuously going, CDC recommends 96 hours, but what Blessy just discussed, the compendium says you're okay to even leave it up to 7 days. And the same answer goes for needleless connectors. Whenever you are changing the line, you change everything. That is the idea. See, please understand, continuous infusion is the one. That means it is maintained like a closed circuit. You cannot connect and disconnect and then say that I will change the line in 96 hours. Anything that is, intermittently used, that lines have to be changed every 24 hours. Okay. I hope that's the CLABSI surveillance rate should be considered dialysis catheters. Now, please understand the central line or central venous access devices. The definition is that the tip of the catheter will be in the thorax, in one of the major vessels. So if the dialysis catheter tip is not in the central line, if it's put in the femoral line only, though it is in a large vein, technically that does not come under central line. So CVADs, so central line associated bloodstream infections are reserved for all the lines which are ending up in the superior vena cava or inferior vena cava or subclavian, the major vessels in the thorax. So even a PICC line which tip is going to reach the thorax will be, known as a central line. Okay. So you must understand what is the definition of central line. So then dialysis catheter, you will only consider if it is in the central line. Otherwise, line-related infections, you can always track. See, just because accreditation bodies and everybody is talking about central line, does not mean you will not track any infection that may come from the peripheral line or from a dialysis catheter. Any line that you put in a patient, if patient develops infection, you will track them separately. But when you actually track CLABSI, the formula says that is secondary to central line. So the definition of the central line needs to be, kept in mind while you are, calculating the rates. So how many days to keep the femoral line? Well, it depends what femoral line you're talking about. If they are central lines, if they are long lines, there is no recommendation to change any of these lines, any particular periodicity. Now observe, and there is only one major recommendations in the maintenance bundle for all lines. This is for lines, tubes, anything, peripheral line, central line, anything that we put in a patient's body. It says assess daily, and if it's not required, remove. That is the fundamental principle. So there is nothing called how many days can you keep. That's not the question. The question is how soon can you remove. That is why that one word comes in all the bundles, daily assessment. It is not only the assessment of the redness or fever, not that. It is also the assessment whether we can remove the line. This is a question that during rounds, John Hopkins has actually asked, do I need the central line? Does the patient need to be on ventilator? Does the patient need urinary catheter? Does the patient need peripheral line? That's a question to be asked and remove them as soon as possible. Like in Hindi, na rahegi baas to na bajegi basuri. So that's very important. So CLABSI surveillance, please make sure that you go and read up the central line, sorry, CDC, guidelines. It has got multiple guidelines. So you have to deep dive. So it's not possible for us to address all that in this webinar. So that is something you need to. Dialysis catheter, arterial line gets infection. No, as I told you, arterial line is not a central line. So that also you can, capture separately that this infection is coming from arterial line. But we know that any of the invasive lines can lead to septicemia in any patient. So that is something you need to be on the watch out. Needleless connectors, we already discussed that, we don't need to. How frequently should we scrub the hub? Is it before every medication? So Blessy will like to answer that. So the question is like in two parts. The question may be they are asking that if I have 3 medicines to give at the same time, do I need to scrub the hub before every medication? or I can scrub the hub once and then give, because there is accession, there is another guideline. It is called saline, medicine, saline. So
Right.
if I have 3 medications, first is, anybody can correct me, scrub the herb
Yeah.
for how long? Can we have it in the chat box? Blessy, you don't answer. How long scrub the herb?
15 seconds, ma'am. 15 to 20
Oh,
seconds, ma'am.
15 to 20 seconds. And after that,
Wait for it to dry.
most important,
Wait for it to
allow
dry.
it
Wait for dry.
dry.
Wait for dry.
Another basic recommendation, wherever you put disinfectant, please remember to wait for it to dry. These timings which are given are kind of, approximate. Maybe in one patient, it may take a little longer. There is a possibility. So you have to make sure whether it is alcohol, whether it is chlorhexidine, whether it is chlorhexidine with alcohol, whether it is betadine, wherever you know, use it, allow it to dry. It may take anywhere from 20 seconds to 30 seconds, maybe a minute also. And if you go and watch your practices, you will see alcohol drying up very quickly. And then the chlorhexidine dries a little bit more fast, slower, and betadine takes longer time. Okay. So the 15 seconds of scrubbing and 30 seconds of drying is what is recommended in the literature. So most important thing is to see whether we are scrubbing for 15 seconds. That's an interesting audit that you can do, because I tell this story in all my classes. We trained our nurses many years ago. We trained them how to do scrub the hub and everything. And after we trained, after some time, I told my educators and ICNs, please go and audit whether they are doing this. Believe me, ladies and gentlemen, they were hardly reaching 7 to 8 seconds. Forget 15. So when we asked them why you are, not scrubbing for 15 seconds, so you should do this exercise yourself. When you scrub something and wait for 15 seconds. So they said, when we are trying to scrub, the doctors who are passing by, they say, what happened? You forgot what you're doing. So they are thinking, these nurses, they forgot what they're doing. For them, it looks like a long time. It's just like your patients after ringing the bell, they say, I'd been ringing for an hour. It's not an hour. It's almost like when the boyfriend girlfriend are waiting for each other, ऐसा लगता है ज़माना हो गया wait करते करते. So like that, our nurses told, then it became our responsibility to educate the doctors that why we are doing 15 seconds of scrub the hub. And that's an interesting thing that you should be knowing. It's only because the research had shown that only after 15 seconds of scrubbing is not even cleaning. That means you literally have to scrub. The hub was found to be minus any pathogenic organism. They actually did culture, CFU's colony forming unit became 0 only after 15 seconds of scrubbing. So till the time we don't have another evidence, we have to follow the 6 to 15 seconds of scrub the hub. And this is very important. And so we talked about changing of tubings and dressings very nicely. Blessy had mentioned. I just want to inform everyone, though we are not there, but abroad, there is something called the nurses are empowered to stop the line. That means if they find the doctors are not doing the right protocol, doctors or whoever is the person who is inserting, if they are not following the right protocol, they can actually ask them to stop the insertion. This is very important for all of us to know. Those who are very much confident, you can, voice up and say, that's it. Because when the initial recommendation came for full barrier precaution, that means the doctor has to wear the cap, the mask, and even goggles, because there is a potential for splash of blood. Though it is not PPE to protect the patient, but the operator, it does risk of having a splash. So we had doctors who were not wearing the gown. They will, especially in dialysis, the doctors will come, wear their regular thing, just wear a mask. And, so in the initial time, it was very important that I was called and I had to actually go and put the cap on the doctor's head and talk to them then and there that this is the recommendation. So I think now things are at least better. It has been a guideline for the last, I think more than 10, 12 years. I think 2008 or 7, I think that guideline came. So I think we answered all the questions, looks like. Hope all of you had a good time. It is 8 o'clock and I'm just trying to wrap up the things. Okay, somebody is telling, Blessy, super proud of you, the way you have prepared your presentation. You articulated, the confidence you have displayed is incredible. It gives immense pleasure to see the younger generation beaming with knowledge and energy. Wishes for you, keep making the difference. And thank you, Sandhya, for that kind words.
Thank you, ma'am. Thank you so much.
I am very proud of all my speakers, and Blessy especially. I think you have a gift of explaining things. So I should not distract you from whatever you want to do, but I think training and education could be your forte.
Thank you,
I'm
ma'am. Thank you so
in
much.
the public forum because it's not very easy for everyone to make things easy and simple and the right things to be told at the right time. That's very important, So fantastic.
Thank you, ma'am.
Thank you everyone for joining in and discussing all the questions, and thanks Sandhya for those kind words. Blessy is super excited and happy, and I'm glad when leaders come here and bless these young next gen leaders. I feel very 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 happy. I mean, that's my intent, to give them opportunities. Great. Thanks, Blessy, and take care. And thank you, everyone. And we will see you again for our last series of the webinar on ventilator associated events, though we are calling it VAP because that's how we are calling it. Pepa will come and explain the difference between VAP and VAE. So see you all in the next session. And thanks, Blessy. God bless you.
Thank you so much, ma'am. Thank you, ma'am.
God bless you. It's very rhyming, eh? Blessy, God bless you. Okay.
Thank you, ma'am.
Okay,
Thank you,
take
everyone, for
care.
joining in.
Good
Thank you,
night.
ma'am.
Night,
Good
everyone.
night. Take care.
Bye.